Case 1. Gastrointestinal system. A 45-year-old female patient presents to the pharmacy complaining of a burning sensation in her chest that worsens after meals and when lying down at night. She has been using over-the-counter antacids for the past 3 weeks, with only temporary relief. She has no alarm symptoms, such as weight loss or difficulty swallowing. The pharmacist suspects gastroesophageal reflux disease, GERD. Question 1. According to the standard treatment approach for a patient with frequent symptoms, more than twice a week, which of the following is the most appropriate initial pharmacological recommendation for an 8-week course? A. Aluminium hydroxide/magnesium hydroxide as needed. B. Omeprazole 20 mg once daily. C. Ranitidine 150 mg once daily. D. Sucralfate suspension 4 times daily. The correct answer is B. Omeprazole 20 mg once daily. Brief explanation. For a patient experiencing frequent GERD symptoms, occurring 2 or more times per week, clinical guidelines, including those from the American College of Gastroenterology, ACG, recommend a proton pump inhibitor, PPI, as the first-line treatment for an 8-week course. Efficacy. PP is like omeprazole, are significantly more effective than H2 receptor antagonists, like ranitidine, or antacids, in healing esophageal erosions and providing sustained symptom relief. Initial management. Since the patient has already tried antacids with only temporary relief and lacks alarm symptoms, which would necessitate a referral for endoscopy, an 8-week trial of a once-daily PPI is the standard pharmacological approach to manage the gastric acid production at the source. Why the other options are less appropriate? A. Antacids. These are best for intermittent, mild symptoms, less than twice a week, and provide rapid but short-lived relief. They do not promote healing or manage frequent symptoms effectively over an 8-week period. C. Ranitidine. While H2 receptor antagonists can be used for milder cases, they are less effective than PPIs for patients with frequent symptoms. Additionally, many regions have moved away from ranitidine due to regulatory recalls, NDMA concerns, often favoring famotidine if an H2RA is required. D. Sucralfate. This is generally used for mucosal protection in peptic ulcer disease or pregnancy-related GERD. It is not considered first-line for standard adult GERD management.
Case 2. Endocrine system. Diabetes mellitus. A 58-year-old male patient with a 5-year history of type 2 diabetes mellitus, T2DM, is currently being managed with metformin 1,000 mg twice daily. Despite good adherence, his recent lab results show a fasting blood sugar, FBS, of 185 mg per deciliter and an A1C of 8.2%. He has a history of a myocardial infarction 2 years ago. Question 2. According to the Ethiopian Standard Treatment Guideline, STG, for the management of type 2 diabetes, which of the following is the most appropriate pharmacological agent to add to his current regimen? A. Glibenclamide, 5 mg daily. B. Liraglutide, 0.6 mg, S.C. daily C. Sitagliptin, 100 mg daily. D. Insulin, NP, H10 units at bedtime. Answer and brief explanation. The correct answer is A. Glibenclamide 5 mg daily. STG protocol. The Ethiopian Standard Treatment Guideline follows a cost-effective, stepwise escalation. When metformin, step 1, at its optimal dose fails to achieve glycemic targets, the recommended next step, step 2, is the addition of a sulfonylurea. Preferred agent. Glibenclamide is the standard sulfonylurea listed in the National Guideline for Combination Therapy due to its efficacy and availability. Alternative considerations. While newer classes like GLP-1 agonists, option B, or DPP-4 inhibitors, option C, are prioritized in international guidelines for patients with cardiovascular disease, they are not the primary second-line recommendations in the Ethiopian STG. Insulin initiation. In the Ethiopian STG, insulin, option D, is typically reserved for patients who fail to reach targets on dual or triple oral therapy, or those presenting with severe hyperglycemia/ketonuria. Case 3. Cardiovascular system, hypertension. A 52-year-old male patient newly diagnosed with grade 1 hypertension, consistent blood pressure readings of 150 over 95 millimeters of mercury, comes to the pharmacy. He has no other comorbidities such as diabetes or chronic kidney disease. He has attempted lifestyle modifications for 3 months, but his blood pressure remains above the target of less than 140 over 90 millimeters of mercury. Question 3. According to the Ethiopian Standard Treatment Guideline, STG, which of the following is the most appropriate initial monotherapy for this patient? A. Hydrochlorothiazide, 25 mg daily. B. Losartan, 50 mg daily. C. Propranolol, 40 mg twice daily. D. Spironolactone, 25 mg daily. Answer and brief explanation. The correct answer is A. Hydrochlorothiazide, 25 mg daily. STG. First line choice. For the management of essential hypertension without compelling indications, like diabetes or heart failure, the Ethiopian STG recommends thiazide diuretics, specifically hydrochlorothiazide, or calcium channel blockers, like nifedipine or amlodipine, as preferred first-line agents. Dosing. The guideline suggests starting with a low dose, such as 12.5 mg to 25 mg of hydrochlorothiazide once daily. Why not the others? Option B, losartan. While ACE inhibitors, or ARBs, are common internationally, the Ethiopian STG often prioritizes thiazides, or CCBs, for initial monotherapy in patients of African descent due to higher efficacy in this population, unless the patient has diabetes or proteinuric kidney disease. Option C, propranolol. Beta blockers are no longer recommended as first-line therapy for uncomplicated hypertension in the national guidelines due to a lesser effect on stroke prevention compared to other classes. Option D, spironolactone. This is a potassium-sparing diuretic usually reserved for resistant hypertension or heart failure, not initial monotherapy. Case 4. Infectious diseases, pneumonia. A 34-year-old male patient presents with a 3-day history of productive cough, pleuritic chest pain, and high-grade fever. On physical examination, his respiratory rate is 22 breaths per minute. Heart rate is 90 beats per minute, and blood pressure is 120 over 80 millimeters of mercury. He is fully conscious and oriented. He has no other chronic medical conditions and has not been hospitalized recently. The clinician diagnoses him with community-acquired pneumonia, CAP, and determines he can be treated as an outpatient. Question 4. according to the Ethiopian Standard Treatment Guideline, STG, for the management of mild community-acquired pneumonia in an outpatient setting. What is the first-line antibiotic treatment? A. Ciprofloxacin, 500 mg twice daily for 7 days. B. Amoxicillin, 1 gram 3 times daily for 5 to 7 days. C. Ceftriaxone 1 gram, IV once daily for 5 days. D. Doxycycline 100 mg twice daily for 10 days. Answer and brief explanation. The correct answer is B. Amoxicillin 1 gram 3 times daily for 5 to 7 days. First-line selection. For previously healthy outpatients with mild CAP, the Ethiopian STG recommends amoxicillin as the primary first-line agent. High-dose amoxicillin is effective against Streptococcus pneumonia, the most common causative organism. Alternative for penicillin allergy. If the patient has a confirmed non-severe penicillin allergy, a macrolide, like azithromycin, or doxycycline might be considered. But amoxicillin remains the standard first-line choice in the guideline. Why the others are not preferred? Option A, ciprofloxacin. Fluoroquinolones like ciprofloxacin have poor activity against S. pneumoniae and are not recommended for pneumonia. Option C, ceftriaxone. This is an injectable third-generation cephalosporin reserved for more severe cases requiring hospitalization, inpatient management. Option D, doxycycline. While listed as an alternative, the standard primary recommendation in the STG for uncomplicated, mild CAP is amoxicillin. Case 5. Infectious diseases. Malaria. A 28-year-old male patient living in Adama presents to the pharmacy with a 3-day history of high-grade fever, chills, headache, and joint pain. A rapid diagnostic test, RDT, is performed at a nearby clinic, and the result is positive for Plasmodium falciparum. He is alert, able to swallow, and shows no signs of severe disease. For example, no jaundice, no confusion, and no persistent vomiting. Question 5. According to the Ethiopian Standard Treatment Guideline, STG, and National Malaria Guidelines, what is the most appropriate first-line treatment for this patient with uncomplicated P. falciparum malaria? A. Chloroquine, 150 mg base, 4 tablets daily for 3 days. B. Quinine sulfate 600 mg, 3 times daily for 7 days. C. Artemether, 20 mg, plus lumefantrine, 120 mg, Coartem, 4 tablets twice daily for 3 days. D. Oral artesunate monotherapy for 5 days. Answer and brief explanation. The correct answer is C. Artemether 20 mg plus lumefantrine, 120 mg, Coartem. 4 tablets twice daily for 3 days. Standard of care. For uncomplicated P. falciparum malaria, the Ethiopian STG and National Malaria Guidelines mandate the use of artemisinin-based combination therapy, ACT. Artemether lumefantrine, Coartem, is the specific first-line ACT used throughout Ethiopia. Dosing. For an adult weighing above 35 kilograms, the standard dose is 4 tablets taken twice daily for 3 days, total of 24 tablets. It is ideally taken with fatty food to improve absorption. Why the others are incorrect? Option A, chloroquine. P. falciparum has widespread resistance to chloroquine in Ethiopia. Chloroquine is only used for Plasmodium vivax infections. Option B, quinine. This is generally reserved for the treatment of severe malaria in IV form, or as a second-line treatment if ACTs are unavailable or contraindicated, for example in the first trimester of pregnancy. Option D, monotherapy. The use of artemisinin derivatives as monotherapy is strictly prohibited to prevent the development of drug resistance. ACTs must always involve a combination of two different mechanisms of action.
Case 6. Cardiovascular system, heart failure. A 60-year-old female patient with a known diagnosis of chronic heart failure, reduced ejection fraction, is currently taking enalapril 5 mg twice daily and furosemide 40 mg daily. During her follow-up, she complains of increased swelling in her ankles and mild shortness of breath when walking short distances. Her heart rate is 78 beats per minute, and her blood pressure is 115/75 millimeters of mercury. Question 6. According to the Ethiopian Standard Treatment Guideline, STG, which of the following medications should be added next to optimize her long-term survival and reduce symptoms, provided her potassium and renal function are normal? A. Digoxin, 0.25 mg once daily. B. Spironolactone, 25 mg once daily. C. Verapamil, 80 mg 3 times daily. D. Hydrochlorothiazide, 25 mg daily. Answer and brief explanation. The correct answer is B. Spironolactone, 25 mg once daily. Evidence-based management. The Ethiopian STG recommends the addition of an aldosterone antagonist, spironolactone, for patients with symptomatic heart failure who are already on an ACE inhibitor, like enalapril, and a diuretic. Spironolactone is proven to reduce mortality and hospitalization in these patients. Clinical goal. While furosemide manages fluid overload, congestion, spironolactone provides neurohormonal blockade, which slows the progression of heart failure. Why the others are not preferred? Option A. Digoxin. This is generally considered a third-line agent in the STG, used mainly for symptomatic relief or heart rate control in patients with concomitant atrial fibrillation. It does not carry the same mortality benefit as spironolactone. Option C. Verapamil. Calcium channel blockers like verapamil are generally avoided in heart failure with reduced ejection fraction because they have negative inotropic effects. They weaken the heart's contraction. Option D. Hydrochlorothiazide. While it is a diuretic, it is less effective than furosemide, a loop diuretic, for managing fluid in heart failure, and adding it wouldn't provide the survival benefits that an aldosterone antagonist offers. Case 7. Neurology, epilepsy. An 18-year-old male patient is brought to the pharmacy by his family. Over the past few months, he has experienced 3 separate episodes characterized by a sudden loss of consciousness, stiffening of the limbs, followed by rhythmic jerking of all 4 extremities. Each episode lasted about 2 minutes and was followed by a period of confusion. The clinician has diagnosed him with generalized tonic-clonic seizures. Question 7. According to the Ethiopian Standard Treatment Guideline, STG, which of the following is the most appropriate first-line pharmacological agent for the maintenance treatment of generalized tonic-clonic seizures? A. Diazepam 10 mg as needed. B. Phenobarbital 60 mg to 100 mg once daily at bedtime. C. Ethosuximide 250 mg twice daily. D. carbamazepine, 200 milligrams twice daily. Answer and brief explanation. The correct answer is B. Phenobarbital 60 milligrams to 100 milligrams once daily at bedtime. First-line preference. In the Ethiopian STG, phenobarbital is recommended as the first-line drug for the treatment of generalized tonic-clonic seizures due to its established efficacy, long half-life, allowing for once-daily dosing, and low-cost/high availability. Dosing strategy. It is typically started at a low dose, for example, 60 milligrams, and increased gradually based on clinical response. Giving it at bedtime helps manage common side effects like sedation. Why the others are incorrect. Option A, diazepam. Diazepam is used to stop an acute seizure or status epilepticus. It is not used for long-term maintenance or prevention of seizures due to the development of tolerance. Option C, ethosuximide. This drug is specifically used for absence seizures and is not effective for generalized tonic-clonic seizures. Option D, carbamazepine. While carbamazepine is a first-line choice for focal, partial seizures, the Ethiopian STG prioritizes phenobarbital, or phenytoin, for generalized tonic-clonic seizures, though carbamazepine is a common alternative. Case 8. Infectious diseases, tuberculosis. A 30-year-old male patient weighing 55 kilograms has been diagnosed with newly diagnosed pulmonary tuberculosis, PTB, after a positive sputum smear for acid-fast bacilli, AFB. He is HIV negative and has no previous history of TB treatment. The clinician is starting him on the standard national short-course chemotherapy regimen. Question 8. According to the Ethiopian Standard Treatment Guideline, STG, and the National TB Program, what is the standard intensive phase treatment regimen for this patient? A. Rifampicin, isoniazid, and pyrazinamide for 2 months. B. Rifampicin and isoniazid for 4 months. C. Rifampicin, isoniazid, pyrazinamide, and ethambutol for 2 months. D. Rifampicin, isoniazid, and streptomycin for 2 months. Answer and brief explanation. The correct answer is C. Rifampicin, isoniazid, pyrazinamide, and ethambutol, RHZE, for 2 months. Standard regimen. For all new cases of pulmonary TB, the Ethiopian STG follows the WHO-recommended short-course chemotherapy. This consists of an intensive phase of 2 months using 4 drugs: rifampicin, R, isoniazid, H, pyrazinamide, Z, and ethambutol, E. Follow-up. This is followed by a continuation phase of 4 months using rifampicin and isoniazid, RH, making the total treatment duration 6 months. Why the others are incorrect? Option A, missing ethambutol. The intensive phase requires 4 drugs to prevent the development of drug resistance. Option B, this describes the continuation phase, not the intensive phase. Option D, streptomycin is no longer part of the standard first-line regimen for new cases and is generally reserved for specific retreatment or resistant cases. Case 9. Maternal health, anemia in pregnancy. A 24-year-old pregnant woman, 20 weeks gestation, presents to the pharmacy for her prenatal checkup. She complains of feeling tired and dizzy. Her laboratory results show a hemoglobin, HGB level of 9.5 grams per deciliter. She is diagnosed with moderate iron deficiency anemia during pregnancy. Question 9. According to the Ethiopian Standard Treatment Guideline, STG, what is the most appropriate pharmacological management for this patient? A. Elemental iron, 60 milligrams daily for 3 months. B. Elemental iron, 120 milligrams, plus folic acid, 400 micrograms daily for 3 months. C. A single dose of vitamin B12 injection D, blood transfusion immediately. Answer and brief explanation. The correct answer is B, elemental iron 120 milligrams plus folic acid 400 micrograms daily for 3 months. STG protocol for anemia. The Ethiopian STG defines anemia in pregnancy as HGB less than 11 grams per deciliter. For therapeutic management, as opposed to routine prophylaxis, the dose is doubled to 120 milligrams of elemental iron combined with folic acid. Duration. The treatment should continue for at least 3 months to normalize hemoglobin levels and replenish iron stores. Why the others are incorrect. Option A, 60 milligrams daily, is the standard prophylactic dose for pregnant women without anemia. Since her HGB is 9.5 grams per deciliter, she requires a therapeutic dose. Option C, vitamin B12 is only indicated if megaloblastic anemia is confirmed. Iron deficiency is the most common cause of anemia in pregnancy in Ethiopia. Option D, blood transfusion is generally reserved for severe anemia, typically HGB less than 7 grams per deciliter, or if the patient is in respiratory distress or heart failure. Case 10. Dermatology, scabies. A 12-year-old boy is brought to the pharmacy by his mother. He has intense itching, especially at night, and small red bumps and thin wavy lines, burrows, between his fingers and on his wrists. Several other children at his school have similar symptoms. The clinician confirms a diagnosis of scabies. Question 10. According to the Ethiopian Standard Treatment Guideline, STG, what is the most appropriate first-line topical treatment and instruction for this patient? A. Hydrocortisone. 1% cream applied to itchy areas twice daily for 7 days. B. Benzyl benzoate, BBP, 25% lotion applied to the whole body from the neck down for 3 consecutive nights. C. Clotrimazole, 1% cream applied to the lesions for 2 weeks. D. Salicylic acid, 5% ointment applied to the burrows. Only answer and brief explanation. The correct answer is B. Benzyl benzoate, BBP, 25% lotion applied to the whole body from the neck down for 3 consecutive nights. First-line agent. The Ethiopian STG recommends benzyl benzoate, BBP, as the primary treatment for scabies. For adults and older children, a 25% concentration is used. It is often diluted for infants. Application protocol. It must be applied to the entire body from the neck down to the toes, not just where it itches. The guideline suggests applying it for 3 consecutive nights, washing it off thoroughly the following morning. Public health note. The STG also emphasizes that all family members and close contacts should be treated simultaneously, even if they don't have symptoms, to prevent reinfestation. Why the others are incorrect. Option A, hydrocortisone. This is a steroid and will not kill the scabies mites. It may actually worsen the infestation while masking the itching. Option C, clotrimazole. This is an antifungal used for conditions like tinea, ringworm, not for parasitic infestations like scabies. Option D, salicylic acid. This is a keratolytic used for warts or calluses and is not effective against scabies.